Hello and welcome to our DMG press conference here at the IDS. I'm very warm welcome from my side. I'm very happy that you had the time to attend this event. We have prepared some fantastic news and products in our DMG world. And without further ado, I would like to introduce you the speakers of today, which is Professor Katrin Bekes. She's the leading expert on MIH in pediatric dentistry. She is professor at the University of Vienna, of the Medical University at Vienna. And she also has written already 3 books on MIH, and that's why she is our key opinion leader on the topic, and I'm very happy for her presentation today. And the second, also very, very important person is the Executive Vice President of DMG, Susanne Stegen, and she would also like to start with her welcoming words here at the press conference. And with that, have fun, and Frau Stegen, the stage is yours.
Warm welcome to our press conference today. I'm very glad that you came and that we're allowed to share exciting news and present a brand new treatment concept. First of all, I would like to start, though, and talk a little bit about my favorite topic, which is DMG, obviously. DMG is a family-owned company. We are based in Hamburg, Germany, and about 500 people work in Hamburg and around the globe in the 5 subsidiaries that belong to DMG to bring modern dentistry solutions to dentists and patients alike. In its history, DMG has been a first mover many times. We were the first to offer cartridge-dispensed temporary crown and bridge material, Laxatemp. We were the first to offer cartridge-dispensed temporary materials, temporary cements and permanent cements with Temposem and Permacem. And we have always looked to develop and patent new technologies. Way back when, the first amalgam capsule. About 20 years later, the Compomer technology. About 15 years ago, DMG started to work ever more closely with researchers and scientists around the globe. And the first result of that cooperation was ICON. ICON was launched here in Cologne at the IDS in the year 2009. And oh my, what a revolution that was at the time. We were the first to be able to say we can treat caries without a drill and treat it efficiently and long-lastingly. ICON, infiltration concept, hence the product name, was actually not designed by DMG. Well, the product was, but the concept was not. The inventors of the infiltration concept were Professors Paris, working today at Charité in Berlin, and Meyer Lückel, working today in Bern, at the University of Bern. And they said there must be a solution to treat interproximal lesions without a drill, because there were only 2 options at that time. Either remove the lesion with a drill and take away lots of healthy tooth substance doing so, probably, or just wait and see if maybe proper remineralization would stop the lesion developing. And they said, well, if we want to treat the lesions properly, we need a new approach. So they designed the infiltration concept, and then they looked for a partner in industry to create the product to go with it. That was ICON. Very soon after the introduction of ICON, it became clear, also even before the introduction actually, to the inventors, that it could not only be used to treat interproximal lesions. It was also a suitable concept to treat white spots, in particular kariogenic white spots. So today, actually pretty soon after its launch, ICON started to come in 2 versions. ICON proximal and ICON vestibular for the treatment of white spots. Once the treatment of kariogenic white spots was established, researchers never stop. They always want to learn more, they want to find new solutions, invent new treatments to better serve patients and protect healthy tooth substance. So white spots, karyogenic, that's one type of white spot, but there are others. So very soon discussions came into being about fluorosis and whether ICON was a suitable treatment for fluorosis. And also amelogenesis imperfecta came into the discussion. The most recent topic being discussed by the researchers, a relatively, the expert may pardon me, new disease, is the so-called molar incisor hypomineralisation, MIH. Known to the press, the non-scientific, non-dental press, as chalky teeth. I just saw, to the German colleagues among you, I just saw a long article at Tagesschau the other day, because this problem has become so prevalent in many countries all around the globe, the chalky teeth, that now public media talk about it. So many children are affected by it. So many parents suffer with their children and look to obtain proper treatment for this developmental defect, if you can call it that. What happens when a child gets MIH? To my understanding, and I'm going to leave it to the expert in just a minute to explain much better than I could, the background, there is no real root cause established to this date. Scientists believe there are many factors that can cause MIH. The teeth that are affected by MIH are the first molars and the incisors. And the incisors look yellowish, brownish, discolored. There are large opacities in them. The molars have an, I would call it, in my layman's terms, unstable structure. Sometimes there is enamel defects up to cavitation in the molars. It hurts, and in particular the incisors with their discolorations cause a lot of trouble to the children, apart from them not being happy when they look in the mirror. Their peers do not treat them very friendly. And they suffer not only from the instability and the lack of aesthetics in their teeth, but also from their friends and the other kids at school not being very nice with them. So it's a psychological problem besides being a medical problem. I don't think I should go any further. I think it's time now that you listen to the expert and explain in better words, more precise terms, what we are dealing with MIH. Professor Bekes, thank you.
Thank you very much. So good afternoon, everyone. Thank you very much for joining this press conference. It's my great honor to give you some more insights into the topic of MIH, which is a condition which is increasing, as we will see. And as already said, maybe most of you know it by chalky teeth or chalk teeth. This is what also parents can read in the newspapers. And what you can see here on the slide is that it's not only a topic in German-speaking countries, it's a topic worldwide. So we as dentists, we do not call it chalky teeth or chalk teeth. We talk about MIH, and MIH is the abbreviation for molar incisor hypomineralisation. I know that it is a very difficult term, and I would like to explain it in a few sentences and also by a few pictures for you. So let's have a look at this patient. It's a patient who is going to school, 8 years of age, a very young patient, and he was showing up just for a checkup in our clinic. And probably if you have a look into these pictures, first you would say maybe, what is the problem in this patient? So the patient himself didn't have problems as well. But if you have a look on the right side, you will see on the upper molar, on the right side, on the outer side, and also on the lower molar, you see very small opacities. And probably these opacities wouldn't have been noticed like 30 years ago. Today, we know that this is connected to MIH. It's a very mild form, and the patient probably will never have any problems with it. If you have a look to this young patient, I think the picture becomes more clearer, because now you see in this back teeth, in these posterior teeth, you see 3 of the 4 first permanent molars being yellowish, being brownish. And also, if you have a deeper look, you see that there are already post-eruptive breakdowns, some cavities that are happening. And this child is 7 years old. So the molars have just erupted, have just come in the oral cavity, and there are already problems. And if we have a look to the anterior region, we see also opacities that have already been mentioned. You see the white and yellow discoloration on the central incisors. You see them in the lower jaw in different colors. And this child was talking about these opacities to us and said, "Can you help me with these opacities?" So what I would also like to show you a third case, a more heavier case, more severe. And interestingly, in this child, there were no opacities. It's just to demonstrate you how variable this condition is. And we cannot make any assumptions if only a few teeth have already erupted and parents are asking us, what about the other teeth? Do they also have this condition? We cannot tell them until the tooth has erupted. So what did we see in these 3 cases? If we want to summarize it, we saw discoloration. We also saw that not every molar has to be affected. And in the area of discoloration, what we also saw that there might be very rapidly a breakdown in these teeth, and also the incisors might be affected. We are talking about a very young disease, a very young condition compared to caries, which we are knowing for a lot of hundreds of years. So we know this condition since 2001. So you have to keep in mind, we are talking about a condition 24 years of age. So a lot is going on regarding etiology, regarding prevalence, and also regarding therapy concepts, of course. And again, because I want to make this very clear, to talk about MIH and to diagnose it, we need at least 1 molar that has to be affected. Of course, the parents in most cases firstly see the discoloration in the anterior teeth, but our look as a dentist goes first to the molars to make the diagnosis. And it's a qualitative defect, meaning during the formation of the tooth shape is totally fine. This is also why we cannot diagnose it earlier, because if we would have a look onto the X-ray, we would see a very nice shape of the tooth. There's only discoloration in certain areas, and this discolored area is porous and might break down, and the enamel, as we have already seen, might appear white, yellow, or brownish. Let's talk a little bit about the prevalence, because everybody wants to know, is this prevalent around the world? Yes, it is. We did an analysis quite some time ago. You see the colored map here. It's prevalent in every continent. We have data from hundreds of countries, and around every 7th child is affected. So we are not talking about a rare disease. It's something that's not only happening in practices dealing with pediatric patients, it's happening in every practice where general dentists are dealing with families. From time to time, they will see patients with MIH. And last week, we got the new data from the 6th oral health study for Germany, and you see here from the prevalence data, it's also every 7th child that is affected in Germany. It's a study that has been done with 12-year-olds, and we are very lucky to have this nationwide data. As I already said, the most burning question for the parents is, what did I do wrong? Why does my child have MIH? Is it nutrition? Is it oral hygiene? So first of all, I cannot solve the problem today for you, but I would like to show you in 2 or 3 sentences why we have such problem in figuring out the causes. What we have to understand is that the tooth is formed years ago. It also takes years to mineralize. Crown mineralization takes place over years, and we will see the result years later when the tooth is erupting in the oral cavity. So we have to look back, and this is what has been done for quite some years, looking back with questionnaires what might have been the reasons, and what we know right now is that it is multifactorial. It's probably not one factor. Seems to be connected with childhood diseases, with antibiotics, and so on. So as you have seen, it's variable. We have mild cases, we have severe cases. And what are the clinical challenges? The clinical challenges for us are teeth might break down, posterior and anterior teeth. The teeth might be very sensitive. The children have a lot of pain in these teeth. There might be also the risk of caries, because if there's hypersensitivity, oral hygiene is not performed very well, and in a second step, it might lead to caries. And from time to time, we see that fillings are not working quite well. And as already mentioned, we have the huge problem in the anterior region with aesthetic, and we know that children really have a problem with it. Because we did some studies regarding this topic, it's called quality of life, where we were asking the patients what kind of problems they have experienced over the years. And of course, this patient might not have this huge problem, because you see it's very small and white opacities, but if you have a look to this patient, you see the huge yellow discoloration, and in this case, we also see a breakdown already. So what we have measured also in our study group is that we have seen that they have impaired quality of life in emotional and social well-being. They are frustrated, they do not want to smile, they do not want to speak with their peers. So what we know for quite some years now is that action is needed, and that we need treatment concepts also for these young patients for the anterior region. So to conclude my first part, I think what we have seen is it's increasingly playing an important role. Again, for the definition, it's not only about the anterior teeth. We need at least one molar to be affected, but incisors might play a huge problem, and it's a disease that every child is affected by worldwide. And the clinical problems are connected with post-eruptive breakdowns, with hypersensitivity, pain, chronic pain, and above all, aesthetics. So this is it from my side for the first part, and I would like to hand over to Ms. Stegen again.
Thank you. So we had discussed before that the researchers continued to investigate which other lesions could successfully be treated with infiltration. And first trials suggested that ICON could also help with the treatment of MIH lesions. I'm very glad, and I think we are also a bit proud, to announce today the first validated, evidence-based treatment concept for MIH lesions worldwide, based on ICON. And let's dive a little deeper. Our clinical research team, the DMG clinical research team, worked very closely with researchers around the globe to establish this treatment concept, and I'm very pleased that Professor Bekes accompanied us from the very beginning, because she's one of the leading experts for MIH worldwide. The treatment protocol offers a minimally invasive approach. The result is aesthetically pleasing. The problems that our young children have because of the discolorations in the front teeth are gone after the treatment, and the affected teeth can be stabilized. The treatment protocol consists of several elements. First one is ICON, as already discussed before, the infiltration. We did our best to make the infiltration more effective. To that end, we improved the part of the ICON treatment that was called ICON dry before. We added monomer to make it prepare the lesion better for more effective and faster penetration of the infiltrant to shorten the treatment time, which is important, of course, with young children who do not like to remain longer in the dental chair than absolutely necessary. Then we also established the synergy between bleaching and infiltration. To treat MIH lesions, especially discolored lesions, well, the brownish part, which are proteins, need to be removed. And this is very effectively done with a bleaching agent. Bleaching in children is not allowed in most parts of Europe, especially not in Germany, and also not in some other parts of the world. Hence, we had to create bleaching, because in this case, it's not about whitening the teeth, it's about dealing with proteins. We had to establish it as a medical device. So our fluoresce bleaching gel with 5 or 10% carbamide peroxide is a medical device for the treatment of enamel opacities, especially MIH, with young children. The bleaching is a step before the infiltration. The lesions need to be conditioned. And as we are bleaching children's teeth, we have to do it gently, and that means the children have to do it at home. To be able to do it at home, they need bleaching trays. And here comes DMG's Dentamile bleaching workflow into play. We have been able to design special bleaching trays that are special because their edge is sealed, meaning we prevent, with the design of our bleaching trays, that any bleaching agent can touch the gingiva, can cause sensitivities. The bleaching agent remains where it's supposed to be. And of course, the bleaching tray can be designed in such a way that only those teeth are being bleached that are being affected by MIH. So we have the Dentamile bleaching workflow with our bleaching trays. We have the fluoresce bleaching gel and the improved icon, which are the 3 steps to treat MIH lesions efficiently. We are looking and working to establish these optimized treatment protocols with researchers worldwide and bring them to dentists and help them to understand the disease, MIH, and how it can be treated effectively with our new treatment protocol. And to show you that it really works, who would be better than the expert again?
So let's talk about the treatment possibilities of anterior teeth, and maybe to show you again the variability about the different severity grades. It's most important to treat children having these yellowish, this brownish discolorations, as we can see here. And maybe to give you some further and some deeper information about the treatment, how this is done worldwide, I would like to introduce you first into the so-called Würzburg concept, which we developed quite some years ago and which is now internationally accepted. So most people around the world ask us, why is it called the Würzburg concept? It's called the Würzburg concept because our working group met in Würzburg quite some years ago. It was before the annual meeting of the German Society of Paediatric Dentistry, and at that time point we thought it would be fine to call it Würzburg. Right now we have realized that the term Würzburg is not so easily to pronounce, but it's established and we cannot change it anymore. So this concept, what was new at that time is that it consists of 2 parts. So we developed a new index based on clinical findings, because at that time point, most clinical indices only focused on the breakdown, saying the more severe the breakdown is, the more severe is MIH. But this is not the whole story about it. So we invented a new index, we developed a new one, and at that time point, we were the first ones connecting a severity grade to a therapy concept, because at that time you could find a lot of severity grades, but no dentist knew how to treat MIH. And I would like to show this to you. So we are keeping in mind not only the post-eruptive breakdown, but also the pain, because I said pain, hypersensitivity is a very strong key symptom in these children, in posterior as well as in anterior teeth. So we are diagnosing MIH, we are seeing a discoloration, and the next step for the dentist would be, is there already a breakdown, yes or no? And is there hypersensitivity, yes or no? And the mildest form would be only a discoloration. And on the other hand, the most severe form would be we have both pain and breakdown. And you can see that this child has pain because you can see the plaque accumulation. There was no oral hygiene performed very well. And what we also learned over years was that there might be mixed conditions. So you could have a child with a breakdown having no pain, which is very nice in practice if you have a child having no pain. But there are also situations where you have no breakdown and the teeth are hypersensitive. And we needed to figure out this for quite a while why this could happen, because usually when you're studying dentistry, you are learning that pain can only occur when you have dentin and dentinal tubules open, but here it's a little bit a different story. So we have these 4 severity grades, and you can also adapt them for the anterior teeth as well, having no breakdown, no hypersensitivity, up to having both. And when we were developing the concept and wanted to provide a treatment plan, of course, we didn't invent the wheel in a new way. In 2016, we had a look into the literature. We knew what was going on in clinical practice and what was working. So it always starts with prophylaxis, with prevention, regular checkups, going and getting more and more invasive depending on the severity. Maybe you need restoration, and maybe at the end, if you have a very heavily destructed molar, you might need also extraction. And this depends a little bit on the severity and also the expectations, of course, of the parents, but above all, as it is always in pediatric dentistry, it always depends on the compliance of the patient, what kind of therapy you could choose. So we developed that concept in 2016, and as you already heard, a lot is going on in MIH research. We are learning more and more. Right now, we are in the very good situation having established therapy concepts, but in 2016, we didn't have all of these therapy concepts, and that was the reason why we recently adapted our flow chart into the Würzburg 2.0 concept, because we updated it. Because, for example, in 2016, our concept did not include any treatment of anterior teeth, and now we know how this is working, and this is why we included it in our concept. So the dentist would read the concept like this. You can see on the left side all of the possibilities. In the first row, you can see the severity grades, and the dentist would diagnose MIH, would make a decision on the severity grade, and then would go into the respected column to find the possibilities of treatment. Today, we would like to talk about anterior teeth, so it gets a little bit more simpler, and I have simplified it much more for you. So we have a prophylaxis part, of course. We have a non-invasive part. We already talked about infiltration technique. And if there are breakdowns, of course, later on, we may have to talk about restorations. But today, I would like to talk about the infiltration. We were interested in this procedure for MIH teeth for quite a long time, but we did have to do a long learning curve, and we learned a lot. And at the beginning, like 15 years ago, we called it more or less like gambling, if it's gonna happen and if it's gonna work or not, because we used the classical procedures that we knew from white spot lesions, from caries treatment. And now we know that we need to approach MIH teeth in a totally different way. So first of all, these teeth need further diagnostics. why do we need further diagnostics? We use transillumination. It's a device, what we usually use in pediatric dentistry to have a deeper look into proximal lesions if we are not able with the child to do any X-rays to see if there are proximal any lesions. In some cases, we use this light also to see cracks after trauma in the teeth, which we would not see in reflected light. And what we have learned over the years is that this device is very, very helpful before we treat MIH, and it should be used on a regular basis. So if you transilluminate a tooth, you see that it gets very, very, very light. You see this is a healthy tooth where we did the transillumination. And this is how it looks like if you do it with a discolored enamel in the anterior region. You see the opacity. What you also see in this picture is that it's not so homogeneous. And we can also have a look a little bit to the borders. Where are the borders? And what we know is that if we use this device, we see much more of the discoloration. We see it much more precisely than what we are seeing under reflected light with just our eyes. And what we also learned over the last years is what we can do with the picture and how we can interpret it. So first of all, we can characterize our lesion. I don't want to go too much into detail, but we know that there are different lesion types in minimum 3. And the lesion type gives us information on how long we have to infiltrate, that it might take longer than the classical procedure. And secondly, we get information in which depth of the enamel the opacity is. So we were assuming in the first years that it's always very close to the surface. But what we have learned with a lot of transilluminated pictures is that if the borders of our transilluminated pictures, if we see the opacity and the borders cannot clearly be seen, probably it's deeper in the enamel. And the time point we did understand this situation, it became clear that maybe with our classical procedures, only cleaning the tooth, applying a little bit of the acid to open porosities might not be enough to get really deep into the lesion and to open the lesion. Because if you do not open the lesion, if you do not open the porosities, icon and infiltration will not work. And with the help of this tool, transillumination, we can now make very clear analysis in which depth of the enamel it is and if we need to adapt the lesion. And I would like to show you some cases regarding this. You see here a very young patient. You see that she has the opacities on the lateral incisors, not on the central ones. Here you can see some more precise pictures. And you can also see what we see from time to time, that maybe also the canine has in the upper third also a discoloration. You can also see that she has already some breakdowns in the enamel. And the first step that we did was that we analyzed the lesions with our transillumination. And what you can see here already is these are 3 different pictures. So the picture on the right, the lesion seems to be totally different than the lesion in the middle. And if you go to the left side, it became a little, it's a little bit, it's not so easy to say where the border, because probably the lesion is a little bit deeper where we knew we have to adapt it a little bit. So as Mr. Ing already said, first after prophylaxis is that these patients get a bleaching tray. The goal is to remove a little bit of the yellowish color, and this is what we did in this patient as well. You can see here the dentamyle system, and here you can see how we did it. We already did the reservoirs for the bleaching. Usually we do it from one tooth behind the canine from the premolar so that it looks very nice. We would not bleach only one tooth because then it would not look so nice if you have one white tooth and the others are a little bit yellowish. And the next point is we do not only want to remove a little bit of the yellowish part of the opacity, but also the healthy tooth color gets a little bit lighter, and we are getting a little bit more closer to the whitish opacity, so that it's more or less similar. So here you can see how we did the bleaching tray. Then we tried it in. It was perfectly fitted, and then the patient was advised to bleach every evening. And what you see 5 weeks after bleaching is that you see now, I hope you have still in mind the pictures before, I can go back, you see that the opacities already get a little bit lighter. The yellowish part was removed. I go back, here you see it a little bit better, it was darker. The discoloration was darker. So what we already achieved after 5 weeks of bleaching is that it got a little bit lighter. Then the patient came to us for infiltration. First thing we are doing is that we are using the rubber dam to protect the rest of the oral cavity. So as we saw that some of the discolored part were deeper in the enamel, we had to adapt a little bit. So we used a little bit of microabrasion to get deeper into the opacity, and then we started with the icon procedure, meaning first of all we did the etching of the tooth, as you can see here, and second step is the application of the icon dry. Then we did a second round with it, and then we started with infiltration. And as I already said, if we see that there are not so homogeneous lesions, but heterogeneous lesions, it might take longer. And this is what dentists have to know, that it might take longer, that we have to adapt it. And here you can see it in the next steps, and this was immediately after infiltration. So what you can see is the opacities have vanished. It's a very nice result. So here you can see the result after 3 months as well, and here you can compare it again, and I think it was a very nice result, and the patient was happy as well. So this is now the usual workflow that we are using in these patients. I would like to show you another patient also. On the lateral incisors, we did have the opacities. Also, the bleaching tray was used in this patient. We will not go to the separate steps. I would only like to show you the transillumination pictures because this is so important now in diagnosis to implement this as well. And here you can see the result afterwards. And if you now transilluminate these teeth, you can see that you do not see any opacity anymore. So the infiltration has worked quite well. So this is the final result, and here you can see it from both sides. So we have done it in a lot of patients now. It's working. Sometimes we have much more challenging patients, as you can see here, with this very, very huge white opacities, or as you can see here in this patient, actually this was the daughter of a good friend of mine, and then you always get a little bit like, oh my goodness, I hope it's gonna work. It has to work, but it worked out in her as well. So I think what you have seen is that with this adapted procedure, with this new procedure, we are now in a really good position to treat this patient. So to summarize, as I've shown you, MIH can affect the patient's quality of life. Transillumination is now very important for us treating the children regarding to get information about the lesion and about the depth of the lesion. And resin infiltration is possible, but we need to adapt the classical procedures. So this was it from my side. Thank you very much. And I hand over to Ms. Stegen again.
Well, thank you very much for supporting us here in our work to establish this brand new, globally first treatment protocol for MIH lesions. I thank you all for coming, and I think Florian Stein is going to lead us through the rest of the conference now.
Yes, so I hope you enjoyed the presentation. I definitely did. We now come to the Q&A section, and I would like to introduce the further participants of that. This would be Florian Bressler. He's our head of marketing communication, who will run around and get your questions. And additionally, if you have some specific product questions, we have also our product owner and product manager here. So the product owner for the digital workflow, Andreas Talarowski, over here. Then we have Leander Kamp. He's our product manager for the bleaching gel. And we have our product product manager for the icon infiltration, Katja Schubert. So I'm waiting for your questions. So let's start. Any questions? Yeah?
A question? Is it? Okay. Yeah, I have a question for Professor Bekes. When I remember right, you showed the map with the affection of MIH, and if I'm not wrong, I think the United States were affected a huge more than, for example, Europe. I think it was red and Europe was green. Yeah. Do you have any kind of explanation, or does it indicate maybe whether something correlates with nutrition or soft drinks, something like that?
Yeah. So to start with your last question, we know that it's not connected to nutrition or soft drinks because it's the mistake is in the mineralization phase, and this is could also be around birth and then in the first years of life. So the teeth haven't erupted yet, so no soft drink can touch this tooth. Regarding the prevalence data, it was a nice world map, but what we have to know is that in most countries it's regional studies or it's studies that have been done in certain cities. So for example, we in Germany are in the lucky position to have nationwide data on the 12-year-olds, but we are more or less the only country having this. So you see a colored map, but it's mostly regional data, and it could be that in this region it's less percentage, in this region it's more percentage. So right now we have a range from 1% up to over 40%, and in the same city we have maybe 20%, and in another part of the country we have 30%. So we haven't solved this problem yet. There were also diving into socioeconomic status, or having a look into, is it more in the biggest cities, and if we go more to the countryside, is it less percentage? We don't know right now. We also have, because I know that when the 5th oral health study was published quite some years ago, there was a big discussion about plasticizers, bisphenol A, and to be honest, we also have it in third world countries. So the problem is right now we can only diagnose it when the tooth erupts. So we are going back, talking to the parents, what might has happened in the first years of life. A lot is going on now with etiology, also in laboratory research. So I hope maybe in the next years we will be able to solve it. But it's multifactorial. It's not only one factor.
Wenn die MIH-Zähne gebleached werden, sind die dann nicht um ein Vielfaches sensibler als gesunde Zähne?
So the question is about bleaching and hypersensitivity. So first of all, not every anterior tooth is automatically hypersensitive. So we experience much more hypersensitivity in the molars. Nevertheless, it could appear. And then we are we are a little bit like we have to follow this. But what you can do during the bleaching process is, if you experience hypersensitivity and didn't have hypersensitivity before, it's the same with healthy patients having no MIH. So they would bleach one evening, and the next evening they would be advised to use CPP, ACP paste, fluoridated paste, to put this into the tray, and then the next day they can use the bleaching gel again. It takes a little bit longer, but nevertheless, now we have also lower percentages in the new bleaching gel, so it would not be so aggressive as well. But nevertheless, if it's experienced, and this is what we also tell the parents, if there is a problem with hypersensitivity, you only do it every second day, and in between you should use a CPP, ACP paste.
Okay, thank you. Okay, so any other question? No. So you have also some material from us which you can read through, and if you have any further questions coming up later, I'm quite sure you can also contact us. You will have also the card from Florian Bressler inside. So yeah. I would like to thank you then for your attention and for participating in our DMG press conference. And thank you to all the speakers and to our participants. And thank you very much, and have a nice day.